Well, hello everybody. I am Stacie Smith, and I'm the Transfusion Safety Officer for McLaren Greater Lansing. I have been with McLaren Lansing for a little over 5 years, with the last 4 years being the Transfusion Safety Officer. So, next slide. So this is what I am charged with talking to you about is transfusion safety and transfusion reactions. So how many med techs do we have in the room? I didn't get a count. So when you look at this slide, med techs are responsible for transfusion safety from the beginning of when we are doing the donor screening and the collection and preparation and testing, all the way through till that last drop is given to a patient. We are responsible for the oversight of that product, and even when we take that back seat in that process. So where it says medical decision to transfuse, this is where we do take that back seat, and the medical decision to transfuse is then where the physicians and the RN step in. And the RN specifically with this point is very critical for patients, in that you guys are the eyes and the ears and the sons and the daughters for those patients, and advocating for those patients and being the voice for those patients that may not need a transfusion, and making sure that it's an appropriate decision to give that patient a drop of blood. Next slide, please. So this is our first case study. This is Augie. And just next slide. I'll give you an overview of who Augie is. He is an 87-year-old male. He presented for an elective hip replacement, and his history is a cabbage times 3, 8 years ago. He has some hypertension that's controlled, and he, at the beginning, prior to his surgery, he had a normal hemoglobin. Next slide, please. So the surgery went on, and it went well, with an estimated blood loss of 500 mLs. He, post-op day 1, was treated for the mild orthostasis with the IV and the oral fluids. Post-op day 2, his morning lab showed that the hemoglobin had decreased down to 8.3 from that 11.2. So the nurse calls physician, lets the physician know what's going on with that patient, with Augie, and proceeds to order the 2 units of blood for that 8.3 hemoglobin. So this is the turning point for this patient. During that second unit of blood, the patient becomes dyspneic, and the O2 sat is starting to drop. So the rapid response team is called, and the patient is then intubated and transferred over to ICU. So next slide, please. So the most likely cause of this acute respiratory decompensation in this patient is the first thing that I would think of is the transfusion circulatory overload. So reason being why that is targeted right, the arrow is pointed right to that transfusion circulatory overload, is the patient received 2 units of blood for an 8.2 gram hemoglobin, and the patient just couldn't handle that much blood being put into him. So next slide, please. So let's talk about transfusion associated circulatory overload a little bit. So it is volume overload. Patients just can't handle that much volume and filtering it through their system. It's the second most common cause of transfusion-associated death, and the mortality rate is 1 to 3%. People who develop that TACO will die directly from those complications. And the incident rate is 1 in 20 transfusions are a TACO reaction. So something to really think about as we continue to talk about TACO. Next slide, please. All right, so TACO is really highly prevalent in our critically ill patients and our younger population, and it occurs anytime up to 6 hours post a transfusion. TACO is also associated with more than 1 unit given, and also with rampant transfusion rates. That's something that I track in Lansing, is how quickly we get blood products to our patients. So how many RNs did we have in the room? How many of you have chased blood with Lasix? Yes.
Yeah, but you also run at 100 versus 150. I'm a cardiology nurse.
So when I'm looking at charts, I'm also seeing that we're chasing this blood with Lasix because these patients are going into overload. So this is where RNs really will directly impact this reaction at the rate that they infuse that blood product. So recommendations from what we have learned in the past was, and I also tell our nurses in Lansing, is minimum of 3 hours for those RBCs to be infused, and minimum of 1 hour for the yellow stuff to be infused, not to exceed 4 hours for either one. And I'll tell you, in Lansing, we're blowing it in, especially the yellow stuff. We're blowing it in wide open. So 5 things that can cause that drowning is the unnecessary excessive orders, so transfusing more units, 2 versus 1, rapid infusion, cardiac dysfunction, positive fluid balance, and then the renal disease that goes along with all these things. And this is one huge issue that I don't think anybody is, it's a mystery to anybody in this room, is Lansing has a huge issue with our renal patients and our nephrologists historically, and we over-transfuse those types of patients. So and despite our numerous efforts to help educate those docs specifically. So in those patient populations, it's created longer lengths of stay to those patients because of those complications following those transfusions. So renal disease is something that I try to keep my pulse on at all times. Next slide, please. So how to spot someone from drowning. So a little bit of personal things about myself. I coach swimming and diving for my local high school, and sometimes, like yesterday, the swimmers really thought that they were going to drown because they had difficulty breathing. They were doing an anaerobic set. Divers, they get really nervous with a new dive and their heart rate starts elevating. Those are things that I watch as I try to throw out my life preserver for those athletes to make sure that I intervene appropriately. So at the bedside, as the bedside caregiver, you are the lifeguard or the coach watching for those changes from that baseline. And during the transfusion, you're on the lookout for those vital sign changes. For TACO, the tachypnea, dyspnea, hypoxia, the rails, and the hypertension that goes along with spotting those changes for those patients that may be experiencing TACO reaction. Also monitoring these patients for those changes up to 24 hours post a transfusion is also important. So even more important to pass on that information to the next shift when you're reporting that this patient received a transfusion 4 hours ago. You know, watch out for these changes in these patients. And in Lansing, we implemented at their shift change, they have a checklist that they have to go through, and that's one of their items on their checklist is whether that patient had a transfusion during their time or not. Next slide. So how to rescue somebody. So when you do suspect that transfusion reaction of any kind, that's when you throw out that life preserver. Stop that transfusion, run that saline, assess your patient, and provide the support that they need. You do not need a physician order to stop a transfusion, but you do need to notify them, obviously, for further guidance, but you don't need that initial order. If a patient is experiencing that transfusion reaction, they need to be assessed and supported appropriately. So along with your physician, you also need to notify your blood bank. So that's also important. We have to report transfusion reactions to our donor center. And when those things occur, we potentially save more lives. And Dr. Hannon is going to talk about another case study here in a couple minutes. We can potentially save more lives when we do make sure that we contact our blood bank. They get that workup, that transfusion reaction workup going, and they also call the blood center to potentially save more lives that other facilities may have other products from that same donor. Next slide, please. So things you can do to avoid that TACO is advocate for those patients that may be on the lower side of the hemoglobin, but may not need a transfusion. They're up, they're conscious, they're talking. They may not need a transfusion, even though they might be at a 6.8 or a 6.9. Monitor your patient during the hours of the transfusion and after that transfusion. Also, 1 unit of blood should theoretically improve a patient hemoglobin by 1 gram. So encouraging that single unit transfusion unless a patient is actively bleeding. And doing that assessment, the physician really should go in and also touch on that patient and reassess that patient in between units of blood if there is a potential for more than one unit to be transfused. And then slowing the rates of transfusion is also something that we need to make sure that we are doing to avoid a TACO reaction. Next slide, please. So the next reaction that I'm talking about is transfusion-related acute lung injury, which is the acronym for that is TRALI. So this is an immune response. It's the leading cause of death, but the incidence is really not known. The TRALI reaction is typically delayed, so it's really long after the transfusion when the patients start exhibiting these symptoms. So the blood is out of sight, out of mind. So they don't always marry the two pieces together to call it a transfusion reaction. Next slide, please. So the risk factors for this, these are just some of them. Prolonged storage of transfusion products, administration of fresh frozen plasma, that's usually a huge culprit for these TRALI reactions, a recent surgery, the cytokine treatment, thrombocytopenia, and master transfusion and sepsis are all factors that can relate into a TRALI reaction. So things that cause TRALI reaction, again, it is a immune response. The patient is responding to that donor. Think of the TRALI car. The TRALI car takes some time to move through the town, so there's some things that are going on physiologically that take some time. So it's going to take some time for those neutrophils to collect into those lungs, causing that respiratory distress and that damage to those lungs, eventually causing the patient to be in the fight for their life. Next slide, please. So how to recognize that TRALI is monitoring those patients again for transfusion changes from the baseline up to 24 hours post that transfusion. Watch for the dyspnea, tachycardia, hypertension, fever, elevation of 2 degrees. Now that 2 degree fever is it's variable because some patients are at 1.5, some are at 2.
Some can actually drop their temperature too.
So some can drop, so you really need to assess your patient and get a collective.
One thing we don't have this x-ray side by side. This one is a whiteout. That's why it's an acute lung injury, and I've actually seen this, and other people have probably seen this. If you looked at the TACO one, it's kind of a fat heart and it's perihylar fluffiness. The important thing about this is you don't necessarily need to sort it out to treat the patient, right? So the patient's having respiratory problems, stop the transfusion, treat them symptomatically, and then over time they can usually sort out whether it's volume overload or inflammatory. My guess, and Erwin, I probably agree with me, lots of times it's mixed. It's probably some combination.
So to go along with this TRALI, and Marguerite's point earlier is finding your why. Why do you want to be a part of this blood management project? And my why is something that touches me very personally is my stepdad had heart surgery at another facility on March 31st of 2014. And everything during the surgery went as planned. It was fine. He responded well. He did receive 2 reds and 1 yellow during that surgery. Post-op, everything was okay. He passed through all of his checks. He was extubated, and about 2 hours after he was extubated, now we're talking about 6 to 8 hours post his transfusion, things started going south. He was tachypnea, tachycardia, hypertension. His fever was increasing. His liver was shutting down. His kidneys were shutting down. His lungs were filling up. He was really a hot mess. He was reintubated, and he was in ICU for another 3 weeks. He was touch and go. We really didn't know if he was going to make it. They drained his lungs. They couldn't get his heart rate couldn't get his heart rate to be back to normal. So all these things were going on with him, and 2 months later, he was in step down. He was back and forth in ICU and step down. So 2 months later, on May the 31st, he was finally able to be released from the hospital. And all this time, with my background and my knowledge and my stepsister being a nurse, we were asking these questions of, could it have been the blood products that he received intra-op? And, asking all of these questions. And they kept saying, no, that's not what it is. But in the end, after we were able to access and sit down with the physicians and look at his chart, it was determined that he was in the fight for his life because of the blood products that he received. It didn't change the care that he got. They did care for him the way he needed. However, the complications that came along with that transfusion reaction, and it was a TRALI reaction, was very hard on him, very hard on the family, and trying to figure out what was going on. And on May the 31st, that's not where his story ended with that transfusion reaction. There was long-term complications that even came after that, and that's one of the things with these transfusion reactions is what goes on after, in the aftermath and down the road. He was in cardio rehab. He was in a rehab facility immediately after he was released from the hospital. He couldn't go home right away. His lungs kept filling up, and he was in and out of the hospital. So there was long-term complications that still were going on because of that TRALI reaction. And do I know if he really needed that blood product when he was in that surgery? We didn't get that far into discussion. But I would say probably not, being that and that's just me and what I'm thinking, being that reaction that he had. But he had that yellow stuff. He had the plasma, which is the typical culprit of that TRALI reaction. And the culprit, in my mind, would be that yellow stuff that he did receive. So did he need that yellow stuff? And being that he only received 1 unit of the yellow stuff, I don't know. I don't know what the answer is at this point in time. I don't know if that we'll ever know. But finding your why of why you want to be a part of this blood management project is important, and that's my why. Making sure that the awareness of that we are giving patients the blood that they need because it's saving their life, but we are reserving it if they do not need it and advocating for those patients if they do not need that blood. So that's my story. Next slide, please. Supportive care, making sure you stop the transfusion, the O2 support, ventilation, intubation, pressure agents, if they do so need that. Those are all things that are critical for those patients. If you have a patient that is in respiratory distress, stop that transfusion right away. Next slide, please. So strategies to reduce that TRALI is appropriate use of those blood products, deferral of donors implicated in TRALI, identification of those multifarious donors, screening for the HLA, the granulocyte antibodies, and then blood that has been stored for a long duration of time. So blood is good for that 45 days. So that also has had an impact on the TRALI reaction as well. Next slide, please. So this slide just kind of speaks for itself. Differential diagnosis between the TACO and the TRALI. The shortness of breath is in both of them. The blood pressure changes. TACO is hypertension. TRALI is that hypotensive reaction. Fever is typically seen in the TRALI with the changes in the temperature, and then the chest x-rays are typically in both. The one difference with the laboratory results is that BNP in that TACO is going to be elevated. In the TRALI, it should typically stay the same.
So for, I know a lot of you in lab and maybe cardiology nursing, but BNP is also something they'll look for, like for CHF, and that's one of the distinguishing factors. Again, ones that I've seen were pretty clear, but there's always those sort of carryover. The most important thing that Stacie said several times is, if you even suspect it, stop the transfusion, treat them supportively, and they can sort out later whether it's TACO, TRALI, or something else.
And those slides right here are very helpful because I have utilized this, laminated them, and threw them on the floors so that nursing always has these available so that they can look and reference.
Yep. Yeah, I like this slide too. And I'm turning it back over to
Oh,
you.
thank you. Well, very good.